Okay. All right. So what we hope to do is, well, I thought for today, we haven't had teaching in a while. And so I wanted to kind of reframe the big picture of traumatic brain injury and increased ICP. Hopefully most of this will be a review, but there are some cases that we can discuss, and in particular, as their care relates to priorities in management in the acute presentation, and then obviously the transport of a child, potential child with traumatic brain injury. And we'll talk about some of the pitfalls and challenges of management as well. Okay. In terms of disclosure, obviously only going to talk about severe TBI and the PICU level management and transport of these patients. We're not going to be talking about minor head trauma today. And then the only other disclosure I have is that you're going to have to put up with pictures of my puppies. So Andy on the left when she was a puppy, and Atlas on the right when he was a puppy. And two different breeders, but the same breed of dog. Anyway, Andy's sitting here at my feet as I speak, looking almost as cute. Okay, so start with a question around cases. So which of the following patients is most likely to have sustained a severe traumatic brain injury? 5-year-old child where the fall was witnessed from a swing. Child had a seizure at the scene and then a GCS en route of 8. And then in the emerge, the GCS is 13. Or the 3-year-old hit by a vehicle traveling 60 kilometers per hour. There's evidence of chest and leg injury as reported by EMS. Or the 12-year-old who was checked into the boards while playing hockey. The GCS was 15 on the ice and the child's talking in the ambulance. Or the 5-month-old restrained in the car seat with a low velocity collision, crying but consolable by the mother with normal vital signs. So what do you think?
I mean, technically all of them could have a brain injury, but
Yeah.
the one that I would be most concerned about would be the 3-year-old hit by a vehicle.
Yeah, excellent, Chantal. Why? What is it about that case in particular that makes you think it might be more severe than the others?
Well, there's no comment on GCS, so I don't know. And then if there's evidence of chest and leg injuries, then likely 60 kilometers an hour, that's like a 3-year-old, they probably have more internal injuries that you can't see.
Excellent. So it's a high velocity mechanism. So mechanism matters. And number 2, there's already signs of diffuse traumatic injury, including chest and leg. And my rule of thumb typically would be if you have injuries above and below the diaphragm, that's diffuse injury, and be suspicious of a severe traumatic brain injury. And really the point is to consider mechanism is really important in raising your spidey sense around, should I be worried about this child having a severe traumatic brain injury? But then also the clinical examination. I also wanted to point out the very first case, the 5-year-old child with the witness fall. That child had a lowish GCS in the field, a GCS en route of 8. But what might have been affecting that?
They were postictal.
Exactly. So it really highlights the importance of taking a really good history from whoever was there who may have observed the injury or the first responders to understand what was going on at the scene, because the presence of that seizure then will affect your opening physical examination when the child arrives to the emergency department, or when you arrive to the emerge to pick up a child, right? If the kid just seized and potentially got anticonvulsants, then that obviously is going to impact your clinical exam. So really, really important from that standpoint too, to understand everything that went on at the scene around the time of the injury. Okay, great. And so, as I said, really, I was hoping that question would help to highlight how essential the clinical history is in assessing for TBI. So again, the severity of the trauma, and Chantal, you did a great job of saying out of these 4 cases, really the one that seems most severe is that high velocity injury. Not only because of the mechanism of the injury, but also the constellation of the injuries, with injuries above and below the diaphragm. So mechanism matters, and the constellation of injuries matter. Okay. We're going to talk about this a little bit more, but any associated hypoxia or hypotension is really important when managing a child with traumatic brain injury, and we'll talk about why. And then associated symptoms, we already talked about the impact of those on your clinical examination. So, for example, seizures, and how either a seizure or being in a postictal state, or drugs that a kid might have received for management of the seizure will impact your clinical examination. And then finally, those interventions such as the anticonvulsants. Okay, so we'll walk through that. But before we do, what is a traumatic brain injury from your guys' standpoint? How are the different ways we can define a traumatic or a severe traumatic brain injury? What makes something severe? Is there a diagnostic criteria, or is there something on clinical exam, or?
I don't really
know,
but like, I mean, I guess seizures would be like something that changes your physiological state.
Oops, sorry guys, I got rid of the Zoom. You still see that? Do you still see that?
Yeah, now we can.
Okay, I was just trying to see if I could get a gallery view, because I can't see, if you put your hands up, I can't see that.
Oh.
So something that changes physiologic state. Okay.
Yeah.
And how about, is there a vital sign that we sometimes rely upon, or a clinical assessment tool that we sometimes rely upon to assess severe traumatic brain injuries?
Well, your neurovitals, but then your heart rate and blood pressure would also.
Which is what's one of our neurovitals?
Pupils.
Okay, what else? You know this, I'm just like
your GCS?
Yeah, exactly. Oh, where'd my thing go for GCS? My slide is gone for GCS, but that's okay. Exactly. And so for severe traumatic brain injury, we'll often talk about, what's our GCS cutoff that we often talk about? A GCS of less than what?
8.
A GCS of less than 8. We'll often also say a changing GCS of greater than 2, right? So if the GCS drops more than 2, you really want to understand what has contributed to that drop in the GCS. And so a GCS of less than 8, or a change in GCS, we will use as a definition for our severity of the brain injury. So kind of have that as a rough guide in your mind when you're assessing GCS. But there is a problem when we assess GCS, and that's different things can impact our ability to quantify a GCS. So another question for you: which of the following is most likely to impact your assessment of GCS? A seizure, a patient who's non-compliant with the exam, a toxic congestion, an inaccurate assessment, or all of the above? What do you think, guys?
All of the above.
Yeah, excellent, Sarandeep. And that's because you can have a kid, a teenager or a 2-year-old who absolutely is not going to open their eyes regardless of what you do. In fact, they're clenching their eyes shut. Or you have an adolescent who's had a toxic congestion. We already talked about the impact of the seizure or anticonvulsant medications. Then the other important one is an inaccurate assessment. So if you've got a clinician at a bedside who is not experienced in assessing GCS, they may not actually have an accurate assessment of the best GCS. So remember, when we're talking about a GCS of less than 8, we're talking about the best GCS. And you guys all know that when you're providing a noxious stimuli, for example, to see a motor response, you really have to provide a true noxious stimuli, right? And so if you've got somebody at the bedside who's actually assessing GCS, and they're maybe not completely accurate with their level of assessment, they may underestimate a GCS and give a GCS of 4 or 5, when in fact the best GCS is 8 or 9. And so just always be wary of that. And so when you guys are out on transport and you show up in an emergency department, you may get handover that this child's GCS is 5. Always split it up. So what are the 3 components of GCS? Just whip through them quickly.
Eye
You said
opening, verbal
eyes,
yeah, eyes,
right?
verbal, and activity or
Right.
motor.
Excellent. Eyes, verbal, and motor. And no harm in using your cheat sheet or reference guide from your smartphone to just remind yourself on the various different responses to get a motor of a 5 versus a 6, for example. So it's always worthwhile to pull a GCS tool out and chart according to that tool. But go back to the patient and do your own GCS and make sure it's the best GCS you can elicit. And sometimes that noxious stimuli has to be pretty robust. So again, just a reminder that GCS, while really important, it isn't necessarily the ideal definition of a severe traumatic brain injury. And so we'll often relate on other things. So a GCS, or rely on other things rather. So a GCS that's deteriorating. And typically we say it deteriorates more than 2 points for no pathophysiological, like for no other reason apart from progression of the traumatic brain injury. So you can't have a kid have a GCS of 12 and then somebody in the emerge gives a honking dose of fentanyl and maybe benzodiazepine for muscle spasm, and then the next GCS is a 9. That's explainable, right? That GCS went from 12 to 9 because of fentanyl and benzodiazepines, most likely. And so that greater than 2 point drop is for a non-explainable reason. Does that make sense? Again, child has a seizure in the interim, and then you're assessing the GCS again in the postictal state. It's not surprising that it will be lower. And so it's always that drop in 2 points for unexplainable reason. Persistent level, altered level of consciousness is going to be important in layering that on your clinical examination. And then obviously we talked about the importance of the mechanism of trauma. There's a big difference between the low velocity car accident where a child was restrained in the back seat. There was no intrusion of the back seat doors. Nobody else was injured in the accident versus a high velocity collision where the back doors are intruded, the child was unrestrained, and there were 2 fatalities in the accident. You almost don't have to hear anything else, right? You're going to address that second clinical case with much more concern around severity of traumatic brain injury than you would the first. Not to say you might have severe traumatic brain injury in both situations, but your starting point with these 2 cases are going to be different because of the mechanism of the trauma. Okay. Sorry, I'm just trying to advance my. And then we talk about primary versus secondary brain injury. And what do we mean by primary brain injury? What does that mean when we talk about primary brain injury?
Like the initial, say, bleed or something like that.
Yeah, the initial trauma that happened, right? So the bump on the head from the hit into the hockey boards, or the bump on the head from the motor vehicle accident, or the skiing injury, the kid going down the hill and running into a tree. That's the primary brain injury. We can't do anything about that, right? And so when we manage traumatic brain injury, all of our management is focused around mitigating and reducing the evolution of secondary brain injury. And so that's what we want to focus on in our transport management. It's this. It's to reduce or mitigate the evolution of secondary brain injury. And when we talk about secondary brain injury, it's really a balance between ensuring that you have optimal cerebral perfusion, optimal oxygen delivery and that we reduce the cerebral metabolic rate. Does that make sense? Okay, so what we're going to do is we're going to talk about both sides of this balance. We'll talk first about the cerebral perfusion and oxygen delivery, which really is determined by a few things. Okay, we're stretching here, but does anybody remember the Fick equation? That's okay. I often will have to look it up too because I'm getting old and my memory fails me. So we'll talk about the Fick equation first. Does that equation ring a bell? This one?
Ish.
It should, because even though you may not be thinking it's Fick, we're managing this all of the time at the bedside. And what Fick says is your oxygen availability or oxygen delivery or oxygen utilization at the tissue bed is related to what's CO?
Cardiac output.
Excellent. Thanks, Sandeep. Cardiac output times your AVO2 difference, which is just your oxygen extraction at the tissue bed. Right? Your arterial oxygen content minus your venous oxygen content. And the difference is what was extracted at the tissue bed. Does that make sense?
Yeah.
Okay. The only other thing we're going to talk about, so if we talk about oxygen content, we have to know what oxygen content, how oxygen content is calculated or what the variables are that contribute to oxygen content. And that's our second equation. So oxygen content is a function of your hemoglobin concentration, a constant, the degree to which your hemoglobin is saturated, plus this tiny factor, which is your partial pressure of oxygen here, times a tiny little factor, constant. And given that this constant is so small, we just get rid of this part because it's irrelevant. And so really your oxygen content is equal to your hemoglobin concentration times your constant of 1.34 times to what degree your hemoglobin is saturated. Okay, does that make sense?
Yeah.
Okay, so we'll talk about expanding on these terms in a second and why they become clinically relevant. But I thought after all that physiology, you might just need to see my doggies again. And I love these pictures because this is when Andy was a puppy and Atlas was about 1.5 years old. And she was dominant right from the beginning. So we would keep him on a leash to kind of try to make sure we could control him. And she would always pick up his leash, like lead him around, lead him to her bed, but lasso him in the process of doing that. And he would just kind of let her do it, passively wander around, and then would just stand there until she let the leash go. It was really funny. And she still is very dominant for Atlas. Okay. So we talked about VO2 and we talked about oxygen content. So then let's put those together. Which of the following has the greatest impact on VO2? Do you want me to remind you of the equations? While you guys are reading the answers or the potential answers. And then O2 content is equal to hemoglobin concentration times 1.34 times O2 sat. Okay. So which of the following will have the greatest impact? The increase in the saturation from 95 to 100, an increase in hemoglobin from 60 to 100, an increase in arterial partial pressure, or all will equally increase VO2?
2.
What do you think? Number 2. Yeah, excellent. And that's just related to this part of the oxygen content equation. right? Now, there can be some argument around this because obviously when we increase a hemoglobin from 60 to 100, we do that with packed red blood cells that have been in the blood bank, and those are old packed red blood cells, and their ability to carry oxygen may be decreased compared to native hemoglobin. But the point of this is really once you're satting well, that small increase is probably not going to increase your oxygen content. Remember the shape of the oxygen hemoglobin desaturation curve, right? You get to that plateau, and an increase from 95 to 100 is not going to increase your oxygen content much. And then remember the arterial partial pressure is always multiplied by that tiny little factor. And so that's not going to do much. So really in a trauma patient who may be hemorrhaging, really, really important to consider what their hemoglobin is. And if they're bleeding blood, you give them blood back, okay, to increase that VO2. Excellent. All right, now let's go to the blood pressure. And you guys have seen this a gazillion times, right? In terms of the variables that contribute to our management of blood pressure. But really important because, again, if we're talking about managing blood pressure, we're talking about managing cardiac output. And that's what we said is important for VO2 management, right? And so really doing a pristine assessment of these things as best we can and managing each of these as best we can. And the reason this is important is because it takes us to another concept called perfusion pressure. You guys hear us use this term a lot at the bedside. What do we mean when we talk about perfusion pressure?
Right, is Kristen here? No.
Sorry.
That's okay. What do we mean when we talk about perfusion pressure?
You have to perfuse your brain.
Well, any tissue, right? So let's just speak generically first. So the pressure to perfuse a tissue, okay? So when we're perfusing a tissue, what matters? The pressure coming in. So you've got, let's say, an arterial or whatever, that's going to divide up to little capillary beds. Then we're going to have a tissue. We'll draw the tissue in whatever color. The tissue is pink. Say we've got our tissue here that's going to get perfused. And then on the other side of the arterial bed or the arterial capillary bed, we have a venous bed, right? And that those things go essentially over to venules and then to bigger veins. So when we talk about mean arterial pressure, which pressure are we talking about? Here, right? The mean arterial pressure is the pressure that is pushing through the arterial capillary bed, pushing blood through that. But is that the only pressure that matters? If it was, we wouldn't be having this discussion, right? What we're talking about is perfusion pressure. And so there's another pressure that matters, and that's the venous pressure on this side. The pressure pushing back, essentially. And so then what's the equation for perfusion pressure then?
Would it just be MAP minus venous pressure?
Outstanding, yeah. MAP minus venous pressure. And again, I said, you guys manage this all the time at the bedside, and you hear the term perfusion pressure, but it's important that we explicitly talk about it this way, and you know the relevance for why in a second. So MAP minus venous pressure. So we'll talk about the renal perfusion pressure. And we worry about, for example, renal perfusion pressure when we get into situations like abdominal compartment syndrome, because abdominal compartment syndrome increases this. It increases the venous pressure a lot. And so the delta P is reduced. The perfusion pressure is reduced. And so the kidneys don't get as much perfusion. And that's why we worry about abdominal compartment syndrome. And that's true for bowel perfusion. Venous pressure increased, MAP may not be increased to the same extent, and delta P goes down, ischemic injury. Because what really matters is not just the MAP, but the MAP in relation to the downstream pressure. Okay, does that make sense? So that's perfusion pressure. So perfusion pressure equals your MAP minus the venous pressure or the downstream pressure. Okay, Chantal, you started to talk about cerebral, the brain pressure. What is another pressure we look at instead of venous pressure with the brain?
ICP.
Excellent. Excellent. And then so with the brain, cerebral perfusion pressure equals CPP equals MAP minus ICP, right? And again, this is what we really care about. Obviously, an important component of cerebral perfusion pressure is your MAP, but we can't just talk about MAP. We also have to think about the ICP part of that equation. Okay, and so if we take that then to, we've already talked about that. If we take that then to saying, okay, the whole point of this was to talk about how to optimize cerebral perfusion and oxygen delivery. The oxygen delivery part is your VO2, that's your FIC. The cerebral perfusion part is your MAP minus your ICP, correct? All right, and so that's why when we started with the very first physiology slide, we said it's really important to think about FIC or VO2. MAP is obviously incredibly important for cerebral perfusion pressure, and ICP. This part is this part of the balance that we'll talk about in a second. Okay, any questions about that? Yeah. No? Okay, so you'll note, just before we go further, you'll note that I'm using the term here, neuroprotective resuscitation. So in the ICU, we'll talk about neuroprotective strategies, right? And that is, our approach to management and application of evidence and guidelines to management of the child in the ICU with a severe traumatic brain injury. When I'm talking about neuroprotective resuscitation, I'm talking about sort of that golden hour, or the first few hours of management of you guys going out and picking up this child from an emergency department. Okay, so the resuscitative part of neuroprotection. Does that make sense? Okay, on that context then, let's talk about the airway. And we'll start with a basic question. Which of the following TBI patients requires intubation as part of their neuroresuscitation? The 8-year-old who fell from the bike and had a seizure on scene. They were given Midaz. They come into the emerge. They're protecting their airway. Their heart rate is 120. Respiratory rate is 23. You see their O2 sats, blood pressure, and GCS there. Or the 10-year-old skiing collision. Loss of consciousness at the scene. You can see their heart rate, respiratory rate, and O2 sats. There's their blood pressure, and there's their GCS. Or the 12-year-old MVC, back seat, they were restrained. There's no other casualties. They do have a femoral deformity, and they were given fentanyl for pain control for that. And there's their vital signs. They're a little bit drowsy in the emerge, and you can see their vital signs. Which one do you think requires intubation as part of their neuroresuscitation?
2.
Number 2. Great, Tristan. Why do you think? What is it about number 2 that makes you worried?
The GCS.
Okay, the GCS of 4, yeah.
And the respirate is high.
Yeah.
And the SAT is lower.
Yeah, it's kind of meh, right?
And he's
GCS is low.
tacky.
Why might he be tacky? I mean, there's lots of reasons for tachycardia, but in this situation, that what we might be worried about. Might be tacky because he's compensating for
blood
his
pressure.
Yeah, excellent. So remember, cardiac output equals heart rate times stroke volume. And so he may be increasing his heart rate to compensate. Why do you think he might have an increased respiratory rate? I mean, again, there could be, maybe he's in pain. But why else? From thinking specifically around a traumatic brain injury, what might he be trying to do?
To lower his CO2.
Outstanding. Yeah. He's trying to increase his minute ventilation potentially. This is what we're worried about. Obviously, we don't know, but this is what we're worried about. And why are we worried about that? Again, going right back as we started. He's got a high velocity injury. He had a loss of consciousness at the scene. He has a low GCS that can't be explained by medications, right? And so it's the gestalt that's making us worried. And then finally, that blood pressure, high or normal or low for a 10-year-old?
Bit high.
Pardon me?
It's high.
Yeah. And again, why might it be high?
Pain,
Pain, why else?
increased ICP.
Yeah. So if it's increased ICP, why is the blood pressure high?
Well, if your ICP is high and you're constricted, your blood pressure has to push harder. So
Yeah. Right. And we'll talk about that nasty little thing called autoregulation, right? But remember, cerebral perfusion is MAP minus ICP. And if we're worried that the ICP is high, then the patient may have autoregulation to increase their MAP. And that's why the heart rate is increased. That's why they're blowing down less CO2 in order to optimize the CPP. So again, tons of physiology just in that little amount of clinical data, which is really important. And it's all those clues that you want to kind of triangulate together to really understand the physiology that's in front of you, because that's what we're going to manage, is that physiology. Okay. So neuroresuscitation, looking after the airway, things that we worry about that are going to push us more to protect that airway are going to be your GCS of less than 8. That's your severe traumatic brain injury kid, potentially, right? Or we've already talked about the dropping GCS. You guys all know what AVPU is. So if the child's not able to protect their own airway, then really important that we do that for them, particularly if we're going to be jumping in the back of an ambulance. Obviously, an airway assessment's important. Is there any trauma in particular? And how are they protecting their airway? And then obviously we'll sometimes in a TBI patient, even if they don't meet these criteria, we'll sometimes intubate a patient just to facilitate management, whether that's a CT or an MRI or surgery. Sometimes they get intubated, or transport. You know, you've got a kid who their GCS is maybe 9, but 20 minutes ago or a half hour ago, it was 10. You're going to get on the road. You're not sure of what direction this GCS is going. You might be having a conversation with your MCO to say, what do you think about managing this kid's airway now before we get in the back of an ambulance? And then it's a discussion. And again, we all know why it's a discussion, right? Why we just don't say, oh, you know what, it's just going to be easier to manage this kid's airway. Let's just put a tube in and then we've looked after things. Well, that's true. Now we have a definitive airway, but at a potential cost, right? Because there's a risk of induction and intubation during the intubation. Risk of induction, what's one risk of induction that we don't want to happen in a kid with traumatic brain injury? If I write that there. What's one risk of induction when we give the medications?
Difficult airway.
Could be a difficult airway, yeah.
You don't want your blood pressure to drop?
Excellent. And most of the induction meds that we're going to give may drop your blood pressure, which are going to drop CPP. Remember, we want to avoid hypotension. So there's a risk, right, to inducing. There's a risk of post-intubation management. So maybe there was a pneumothorax that wasn't appreciated that you convert to a tension pneumothorax, for example. And then you lose your important clinical examination. We know that, right? Now we've got a sedated kid versus a kid who's awake, who we could be doing serial vital signs and GCSs on. So there are risks to intubation, and that's why we want to be very thoughtful every single time we make a decision to go ahead and intubate. Okay, so again, when we're managing the airway, these are our goals. We want to avoid desaturation in order to optimize oxygen delivery. We want to avoid hypotension in order to optimize cerebral perfusion. And we want to avoid increases in ICP in order to optimize cerebral perfusion. Does that make sense? Really, really important. And we know each of these things can happen during an intubation. So again, intubation is a risk in a patient with traumatic brain injury, and we really need to be thoughtful with a procedural pause. And oops, what the heck happened there? We need to be thoughtful with a procedural pause and really engage the entire room around what our goals for induction and intubation are and what we're trying to avoid. So these are the procedural pauses in the room, in the community, where you're saying, okay, guys, listen, this is a kid with traumatic brain injury. We really need to optimize cerebral perfusion. And for that, we want to avoid hypotension. We want to avoid this kid coughing and bucking against an endotracheal tube. And we also want to avoid desaturation. So this is how we're going to manage things. So really important to create that shared mental model. Okay. So based on that, then, let's go to another question. You have a 4-year-old with severe TBI in need of intubation. You see their vital signs there. Which is the most appropriate choice for induction? And anybody can shout out your answer.
I'd say propofol. And I hesitate to say without paralytic because it makes me uncomfortable, but with a GCS of 4, we may not need it. But I would say propofol, and I don't know. Now I'm second guessing myself.
Again, so go back to first principles, go back to your physiology, right? Go back to this slide.
Yeah.
We want to avoid desaturation, we want to avoid hypotension, and we want to avoid increases in ICP.
So I feel like your blood pressure is very robust. So I wouldn't.
Why is that blood pressure robust?
Well, yes, I understand he's probably trying to regulate. So you wouldn't want to drop that too much, I guess. So maybe not propofol then.
Maybe number 1.
Number 1, okay. And why do you say number 1, Tristan?
Because 2 and 3 have propofol, they're going to drop your blood pressure. And same with ketamine.
Does ketamine drop your blood pressure classically?
Or no, isn't it reserve it?
Yeah, so ketamine has intrinsic sympathomimetic activity.
Or maybe number 4?
So number 4, you'll get a retained blood pressure most of the time. I mean, ketamine, even if somebody is maximally sympathetically driven, ketamine can also reduce blood pressure. But typically it's known to maintain a blood pressure. And paralytic, why might a paralytic be important?
Yeah, to decrease your ICP.
Yeah, right. So this is going to protect your MAP. This is going to protect your ICP. You're going to avoid the patient bearing down when you put that laryngoscope in the back of their throat. So yeah, the challenge with propofol with or without ROC is that you're going to drop your blood pressure.
So I have a
So,
question. So say this child's heart rate was not 135 and it was, I mean, 4 years old, say it's 70 or 60.
Yep.
In that case, would you still wouldn't use propofol because you still don't want to drop, like, you want a normal blood pressure, but you don't want to drop it quickly. Is that correct? Because then you're
you don't even want a normal. This blood pressure
Mhm.
is physiologic for this child to maintain their CPP.
Okay, so they're
Right.
just right. So it wouldn't matter if they were like, it wouldn't matter. You just don't want to drop the blood pressure.
We don't want to drop the blood pressure because if we drop the blood pressure, that's 1/2 of the CPP equation. We're going to drop the CPP.
And you may drop your ICP enough, some as well, but you wouldn't drop it enough to protect your CPP.
Correct. Correct. And that's why we'll use ketamine.
Okay.
Okay. So ketamine and rock. This one is not a great choice regardless, because I wouldn't, unless there's an absolute contraindication, such as a smashed face, for example, which I didn't tell you that, but unless there's an absolute contraindication to give him a paralytic, I would intubate this child with a paralytic. Midaz and fentanyl, again, ideally we want to paralyze. Midaz and fentanyl is not a horrible choice if those are the drugs that the community is familiar with. You'll probably be able to protect blood pressure better than you would with propofol. The issue with number 1 is it said without a paralytic. And again, unless there's an absolute contraindication, like a facial smash, unable to bag the patient situation, then you would want to paralyze to avoid coughing, bearing down against the laryngoscope, and to optimize your view, quite frankly. Okay. So bearing in mind no other absolute contraindications to using rocuronium, we agree that we want to paralyze to manage the ICP component, and ketamine is probably your best bet to mitigate against drops in your MAP and protect your CPP as best possible. Okay. All right. So let's say we get this patient intubated then. Which of the following? The RT asks. The RT out in the community says, okay, you got your endotracheal tube. How can I help you set up the ventilator? Which is the most appropriate? Kid is 20 kilograms. Tristan, Serendip?
I'd say number 3.
Tidal volumes of 100 to 120 mils and a target normal saturations, and end titles of 35 to 40. Excellent. What was it about number 3 that was pushing you to number 3?
So I knew, I knew tidal volumes, we want like what, 5 to 6 per mil.
Yeah.
And then normal sats, because there should be no reason that they don't have normal sats. It's not a lung issue.
Right.
So I mean normal sats. And then the end tidal should be like 35 to 40 is our ideal. I don't think that saying less than 40 is like, I don't know, number 1 to me, like, yeah, less than 40, but like how much less? And then I don't think you want like certain pressures, because again, this kid has normal lungs. If you're hoping they have normal lungs.
Well, and again, peak inspiratory pressures in and of themselves don't tell us anything about what the tidal volume is, right?
And you don't want permissive hypercapnia for sure.
We don't want that. Exactly. And why do we want end titles or CO2s 35 to 40? Oh, geez. 35 to 40. Why? What's the physiology there for CO2?
I feel like I'm talking to it.
No, that's okay. Well, this is the physiology. Remember, we talked about cerebral autoregulation. Okay, so down here on the x-axis, we have cerebral perfusion. And on the y-axis, we have cerebral blood flow. Okay. The brain wants to maintain normal cerebral perfusion. Okay, and that's what cerebral autoregulation is. It's an adjustment of your cerebral perfusion pressure to maintain constant cerebral blood flow. You see that? It's constant. Your cerebral perfusion pressure will increase and decrease to keep your cerebral blood flow constant. Now, a couple things. During traumatic brain injury, this relationship probably is disrupted to some extent. Okay, number one. Number two is understanding how the cerebral perfusion pressure changes. And the way cerebral perfusion pressure changes is each of these things. Okay, you get a change in myogenic tone. You get a change in neurogenic responsiveness of the vasculature. You have endothelial messengers that affect your vascular endothelium, the smooth muscle around your blood vessels, and you have a metabolic control mechanism to affect vasoconstriction and vasodilation, which is what's being shown here. Okay, this up here is vasoconstriction and vasodilation. The thing we can control is the CO2. All right, so when CO2 goes high, the brain detects CO2 by chemoreceptors is high. What does the brain generally want to do? It sees high CO2, so what does it want? Does it want more or less blood flow?
So Sandeep typed in the chat. I don't know if you can see.
Oh, I can't. No, I can't.
So he said decreasing CO2 causes vasoconstriction equals a decrease in cerebral pressure.
A decrease. Okay, good. And then vice versa. So if the brain sees high CO2, the brain thinks, I need more cerebral perfusion. I need to wash out this CO2. I'm going to vasodilate to wash out more CO2. So this is going to increase cerebral perfusion pressure. Or not increase cerebral perfusion pressure, but increase blood flow. And if the CO2 is low, the brain thinks, I've got tons of blood flow. I don't need this much. I'm going to vasoconstrict. Exactly as you said, Serendip. And so we don't want swings in CO2. We don't want CO2 to be high. We don't want CO2 to be low. Our goal is CO2 35 to 40 to avoid vasoconstriction on that side and vasodilation on this side of the CO2. Does that make sense?
Yeah.
Okay. And we manage that all the time, right? At the bedside. Again, physiology, so I had to show my doogies just to everybody take a breath and we'll calm down again. And then we'll talk about more clinical stuff. All right. Okay. And so we talk about this stuff all the time. All right. Now we'll go to neuroresuscitation of ventilatory management. We already talked about our target tidal volumes. And again, typically we're going to target a 5 to 6 mil per kilo with a goal for a CO2 of, this is 35 to 45, really, that should be 35 to 40. Sorry, that was a typo. Normal CO2s, and we talked about why. And you're always going to want an end tidal monitor in line, and you're going to calibrate that, as you guys know. And why do we want to maintain normal oxygen saturations?
Perfusion of brain.
O2 sats, does that perfuse the brain? Remember?
Yeah, your O2 content. So you want
Yes.
available for oxygen delivery to the brain.
Excellent. And that's why PEEP is important. Do you guys know when I started, that's how long ago it was, we would often ventilate people with 0 PEEP because there was a worry that PEEP would translate to high venous pressures and increase ICP. Obviously, we don't do that anymore because we understand that it's important to maintain normal oxygen saturations, and so we need to avoid atelectasis. And so our goals of ventilatory management, and you guys know this, are normal CO2 and normal SATs. Okay. All right. So we already talked about some of this, but we'll talk about it in more depth. So from a circulatory management, we know we want to avoid hypotension, and I should have even put in here relative hypotension, because not even hypotension according to age, but hypotension according to what the child's blood pressure is doing. And so I think that was whatever it was, a 10-year-old or something had blood pressures of 145 over whatever it was, 95. We know that blood pressure is relatively high for a child, but we understand why it's high. And that's probably high because of increased ICP and autoregulation. And so not only do we want normal blood pressures, or we want to avoid hypotension, we also want to avoid dropping the blood pressure from what it is, because this blood pressure is a physiologic response to that high ICP. Okay. And ultimately our goal is to maintain CPPs of greater than 50. And again, remember, we've got it here. CPP is MAP minus ICP. Okay. Now I will tell you the guidelines will say a minimum CPP of 40. All of us think that that's pretty low though. I mean, that's a minimum CPP if you've got refractory high ICP and you can't get it down. But really, a CPP of 50 is what we try to achieve. I'm just aware of time, so I'm going to just speed up a tiny bit. Is that okay? And we know that there's various ways that we manage mean arterial pressure. And again, most importantly, what we want to do is we break down mean arterial pressure into its 2 components, cardiac output times systemic vascular resistance here. And then we manage both of those components. Okay, so we know stroke volume is preload, afterload, contractility, and we can manage preload, crystalloids, and like target a CBP. What would your target CBP be if you happen to have a central line on transport?
I'd say between 8 and 10.
Outstanding. Yeah, you want your CBP about 10. Too much higher than that, and then you worry about promoting cerebral edema by pushing fluids. And I should have put in here, because this is a trauma patient, always think about potentially blood as well, transfusion. And then contractility, we know the inotrope of choice is going to be epinephrine to increase contractility. And then increasing SVR by vasoconstrictor or norepinephrine. That's a total typo, norepinephrine, that should say. Okay. So we manage each of those things when we manage the circulation. Okay, let me keep going. And then I'm just trying to, okay, so now what we're doing is we're going to manage this part of the CPP. Remember, we talk about managing MAP, but now we need to manage this component because it's CPP isn't just MAP, it's MAP minus ICP. And there's various things that we manage in managing ICP, right? So remember, is everybody okay to stay for like another 5 to 10 minutes? If you have to drop off, I appreciate that. We started late. So ICP is a function of what's inside a closed box, the cranial vault. Okay. And we know within the cranial vault, we have brain, we have blood, we have blood that's intravascular, we have blood that's extravascular, and we have CSF. Brain translates to edema, right? To brain tissue edema. Blood that's intravascular, we've already talked about vasodilation and vasoconstriction. Extravascular are things like hematomas. And then CSF. And so each of these green boxes then talks about how we would manage each of these four components within a closed box within the cranial vault. Because ultimately, with it, if you're in a closed box, if we increase the volume of any one of these, we're going to increase the pressure within that box. Does that make sense? Right. So for the brain, we need to manage cerebral edema. And how do we do that? Keep the head of the bed elevated and 3% saline. For intravascular, we already said we want normal O2, but we want to keep a normal CO2 because we don't want vasoconstriction or vasodilation. We're also going to avoid hypertension. So if the kid has a blood pressure of 120/80 and they're coughing and bucking against the endotracheal tube and that increases to 160/100, we want to avoid that because an increase in blood pressure will also increase the intravascular blood component. And that's why sedation, analgesia, and paralytics are so important. Keeping the head of the bed midline and the C-collar on, but not particularly tight, is important for venous drainage. Okay. Extravascular blood, we can't do a heck of a lot about. That's a neurosurgical treatment, right? We need somebody to go in and evacuate the big hematoma. So we're not going to do much about that. And CSF, while you guys are on transport, you're probably not going to do about that and much about that. That's, again, going to be a neurosurgical management. So the things we can do something about are your cerebral edema and your intravascular blood. And that's why CO2 is so important to manage. Okay? Does that make sense? All right. Just kind of moving ahead of my slides. Sorry for a second. Okay, we're going to talk about this for a second, the Monroe-Kelly doctrine. And Monroe-Kelly says that the brain, the intracranial vault, can compensate. So you can have increases in edema or increase in blood to an extent. We can increase the volume within that box to an extent before we get the increase in pressure. So you see, you don't get big increases in pressure down here in the A zone, even though we're increasing the intracranial volume. But eventually we lose compensation at point B. And a very tiny increase in volume now relates to a much larger increase in pressure. And then by the time you get to C, like a minuscule change in volume causes a very large increase in pressure. And so really our job is to keep the kid down here on this part of the curve and to recognize when they're creeping in this direction and approaching point B. Does that make sense?
Yes.
Okay. And so I think the slide I'm going to close with is just because unless people are okay to stay, I can stay. Is everybody okay to stay for a few more minutes?
Yeah, that's fine.
Okay, so we'll keep going. You tell me if you need to jump off and then I'll stop, okay? So let's go through this then. So you've got a patient who's 24 hours post severe traumatic brain injury. The patient's intubated, they're ventilated, and they're being managed with neuroprotective strategies. You're called to the bedside because the patient's tachycardic. The remainder of the clinical exam is unchanged. Which is the most likely zone of the Monroe-Kelly doctrine for this patient? Where do you think this patient is sitting? They're 24 hours post and they're tachycardic. Nothing else has changed.
B.
Did you say B, Serendip?
Yeah.
Excellent. That's exactly right. That's exactly right. If there was more change in the neurologic status, I would say patient probably is here, you know, a pupillary change, hypertensive, altered level of consciousness, impaired gag response, impaired motor responses. But really all we're seeing is tachycardia, and that's telling you that this child is trying to compensate. So they're down here on the Monro-Kelly. But it's important, right? Because if you don't recognize that, you're apt to go to the bedside, not you, but any of us are apt to go to the bedside and say, oh, this patient's tachycardic because they're in pain. I'm just going to give a bolus of fentanyl and then walk away and go see my consult in the emergency department. Really, really important to understand that a very subtle clinical finding is telling us loads of volume about where this patient is sitting on the Monro-Kelly curve and the potential risks. Because if we just give that fentanyl and then walk away and go see our consult, the likelihood is they're going to continue to creep up that curve as their cerebral edema gets worse. And the next call to the bedside is going to be for a change in motor responses, or for hypertension, or for a change in pupillary reflexes. So the Monro-Kelly doctrine is really important. Okay, let's keep going. Not going to talk too much about this because you guys already know about intracranial pressure monitors, okay, and the various different types, right? So here's an interparenchymal one that sits in the tissue that obviously you can't drain from. Here's an intraventricular drain that sits in the lateral ventricle, and that's great because we can drain. And then we have bolts, which will sit and measure pressures in the subarachnoid space. And really the only one we can drain from is going to be that intraventricular drain. Okay, in which of the following patients would ICP monitoring be most useful? So you can have a look at your 4 options. So what do you think about number 1? 3-year-old TBI, severe mechanism, intubated for procedural sedation, responding to external stimuli now, and is requiring escalations of sedatives to keep them down because they're responding normally to their external stimuli. Or the 2-month-old, pardon me?
Sorry, I was gonna say, I don't think that one needs.
That one is, yeah, that one, when we examine, it seems to be responding normally. So it's telling us a lot, right? Just from the clinical examination. Or the 2-month-old who has a TBI, they're intubated and they have a flat fontanelle. Or the 3-year-old TBI has a cranial bone flap for decompression. Or the 3-year-old severe TBI, severe mechanism of injury, depressed level of consciousness, diffuse axonal injury. Which one do you think?
I'd say 4.
Yeah. And the reason for that, again, is in the first one, we've got a clinical exam. ICP is never going to tell, an ICP monitor is never going to tell us more than our clinical examination. So ideally, if we can maintain a clinical exam, that's what we want. In this situation, the kitty has a fontanelle. So they're not like where we saw that closed intracranial box. They've got this. Right? A closed whatever. They've got open fontanelles. And so if they have high ICP, that box just expands. So they get less, they're not as at risk for the Monro-Kelly and that increased volume translating to a high ICP. Does that make sense? On top of which we have a fontanelle. That's our ICP measurement right there. We can feel to see if the ICP is increasing. In this kid, they've already had a decompression. So to put in an ICP monitor, it's not going to be reflective of the total intracranial ICP because the patient is going to be decompressing out of the area of the bone flap. So this one is correct. 4. Okay, good. We've talked a lot about that side of the balance. what about here? What are the things we do at the bedside to reduce, or you guys are gonna do on transport to reduce, think about it, cerebral metabolic rate?
Sedation.
Sorry,
Sedation.
sedation, okay. Good,
Cheryl over here says normal thermia.
good, because we want to avoid hyperthermia. Increased temperature will increase metabolic rate, good. What else?
Would you like, if they're having seizures, would you treat the seizures, obviously?
Yeah, we want no seizures, excellent.
Keeping your CO2.
CO2 is gonna be over here, right? On that part. What happens if they are getting warm and we have to cool them down? What do we want to avoid when we're cooling them?
Oh, you don't want them to shiver.
Yeah.
No shivering, good. What fuel source does the brain like and will feed the brain? That we won't put in their IV for the first 24 hours, usually.
No,
Yeah,
no.
no dextrose, good. Good.
With a few hints. Very good.
No, that's great. Okay, so with those in mind, let's go to a question. Which of the following empiric therapy should be initiated in an intubated child with severe TBI? Empiric, we're just gonna do it regardless. Antibiotics, anticonvulsants, paralytics, or 2 and 3?
Two and
Two and
three.
three.
2 and 3.
Anticonvulsants, paralytics, 2 and 3. This one's a little bit debatable. I mean, someone might say if you can give enough sedation, analogous sedation and analgesia to keep the kid completely flat, then maybe you don't need to paralyze. But we want this child completely flat, no coughing, no gagging. We want to take over ventilation to control CO2. So in most cases, we are going to paralyze as well. Excellent. And again, we've talked about most of this. So we do not want this child to seize. And we're going to give them prophylaxis because now we have a sedated patient who's paralyzed. We're not going to know if they're seizing until we get that 24-hour EEG. And we're going to obviously monitor and treat for seizures. You guys talked about the normal core temperature, so we're going to monitor esophageal temperature. We want the blood glucose to be normal because we don't want to feed the brain. And so we're going to avoid dextrose until they need dextrose. We certainly don't want them to be hypoglycemic, but we want to avoid blood glucose is greater than 10. And we're going to be very aggressive with sedation and analgesia and paralytics if needed. And don't forget about simple things like a bowel regime. Because remember, increased abdominal pressure goes to where? It increases intrathoracic pressure. And if intrathoracic pressure is high, then we need to increase the PEEP. And if we increase the PEEP, we increase jugular venous pressure. Right? And so we want to make sure we're also managing a very aggressive bowel regime.
Yeah.
And again, sorry, did you have a question?
No, Cheryl and I were looking here like we thought just so they don't bear down, but that also works.
Yeah, true. Oh, okay. No, this is why though. Yeah, because abdominal pressure will translate to an increased jugular venous pressure. And then finally, assess your patient. So really, really important that if you get called to the bedside or you're managing increased ICPs, really important to go and look for correctable causes. Right back A, B, C. Is the airway where it's supposed to be, or has it migrated deep? Is there water in the ventilator tubing? Does the patient need a suction? All of those things will lead to increased ICP. what's the end-tidal CO2 doing? Has it crept up? Because, for example, mucus in your endotracheal tube. What's our level of sedation, analgesia, and paralytic? Pushing 3% saline. And again, we may be targeting sodiums of around 160, 155 to 160 to really push those sodiums up. If you have a drain in, you can drain your CSF. And then obviously thinking about things like CT scan. But the important part of this that I really wanted to highlight is most things can be managed. Most increases in ICP can be managed with these. And don't forget to look for correctable causes and to optimize your ABCs. You know, making sure, for example, that the head's midline and that the patient isn't crunched down on one of their jugular veins, which is impacting jugular venous drainage, for example. Okay. And then in here, I've included some references to the guidelines for pediatric severe traumatic brain injury, which I'll include in the recording that I upload to our YouTube channel. Is that okay? Okay. And then I just finished with the cuties again outside in the garden because, you know, that makes us feel calm again. All right, I'm going to stop recording. And I think I'm going to stop recording. Stop recording.